Thank you very much. Good morning. Thank you very much, Naren, for your efforts in organizing this webinar. Good morning for all of you. I think you can, I'm sharing the screen, so I think you see my slides. Am I correct? Okay, fine. So I work in the south of Italy, in Bari, and as you may know, we have the, oh, I cannot, okay, right. As you may know, we have the dubious honor of the highest number of infected people in the world now after US. We have about 90,000 infected people. In the most stricken area, which is the Lombardia, with Milano as the main city, they have about 40,000 infected people. And from 20 hubs for neurosurgery, for 10 million inhabitants, now they have just 3 main hospitals where they do surgery, which are Milano il Niguarda, Varese, and Brescia, which is mostly in the north. In our region, which is the Puglia, we have 4 million people, and from 9 hubs for neurosurgery, we've reduced the number to 6, but all of them are depotentiated because all these 6 main hospitals receive COVID and non-COVID patients. And I have to say that the health politics in Italy are decided by the regional governments, mainly. The centralization of the COVID patients in main hospital has some advantages to offer patients, COVID patients, a highly specialized and multidisciplinary care, especially for patients with multi-organ failure. And 1 patient out of 3 have the involvement of, apart from lungs, of kidney, liver, brain, and muscles. But the drawback is that the centralization of COVID patients in main hospitals has paralyzed the tertiary care, with obviously a degradation of the quality of care for non-COVID patients. If driving accidents and working accidents have diminished, ruptured muscular malformation did not. And actually, we found an increased referral of tumor patients, maybe for the fact that the traveling is now forbidden. This is the new order. We can really talk about a new order. End of February, at the beginning of the outburst, patients with positive of COVID were hospitalized here, which is the infectious building, the infectious disease building. They were also hospitalized there, okay, sorry, okay, here, which is the pneumology, and here, which is one of the general medicine wards. Since the 14th of March, we've centralized all COVID patients here. This building, the Asclepius building, is the building for the most specialized surgeries, including neurosurgery. So the surgeries that were located in this building have been scattered all around in the hospital, including surgery, neurosurgery, to have the possibility to increase the beds, the ICU beds that are now about 70 from the 24 we had before the outburst, and to increase the beds, ward beds for COVID that are now 300. Neurosurgery has been moved in the orthopedic building here. From 30 beds, we have now 10 beds. From 18 dedicated nurses, we have just 6 dedicated nurses. All the others are affected through the COVID buildings. And from 8 to 20, I mean 8 a.m. to 8 p.m. OR accesses weekly. We have now the possibility of 3 weekly access, 8 to 20, in the non-COVID building. The orthopedic OR is obviously smaller, the lower sterility standards, which we had to equip with our technology. And we have obviously also a COVID ward in this building with an OR dedicated to COVID patients, and operated patients are scattered. We don't have any neurosurgical COVID ward. Our patients are scattered all around the 5 floors of the COVID building. Currently, we have 140 COVID patients. 25 are intubated, 40 have a CPAP, and 75 are, in the regular beds, in the regular wards. In order to meet a further probable increase of demand of care for COVID patients, pre-hospitalization and outpatient setting is currently completely shut. Pre-hospitalization is cancelled. There is no secretary. Outpatients is possible only for oncologic patients, urgent cases that have, the urgent cases have to be referred by other doctors. The rehab is currently working. The adjuvant treatment for oncologic patients also working with a lot of difficulties. And obviously we had to drastically reduce scheduled patients. We currently treat just emergency patients and urgent oncologic patients. What did the direction of the hospital did for supporting us, support the patient care in this new order? Telemedicine was maximized. This is a good thing in order also to reduce contacts with patients and between doctors and paramedics, and to speed up the care. Now, as you have seen, we have 2 separate hospital sections in a same hospital with wards no COVID and wards COVID positive. The nurses that work in the ward which is COVID positive, they are confined in the COVID positive wards, and the opposite is also true. Nurses that work in no COVID section, they work just in the no COVID section. There are no crossovers for nurses working in the wards. But the problem is that surgeons, anesthesiologists, and operative room nurses, they work in the same time in the no COVID and in the COVID section. There are crossovers between the 2 sections for surgeons, anesthesiologists, and operative room nurses. And this is true for most Italian hospitals. As a consequence, in Italy, we have the 10% of infected patients are medics and paramedics versus 3–4% in China. In Italy, 1 patient infects 7 subjects, mostly in hospital. Hospitals now are the main, as outside nobody gathers. There is any kind of manifestations forbidden. The hospital now is the main place where the outburst grows. The other problem is that often the no COVID organization gets stuck for the COVID alarm, obviously regarding possible exposition of personnel to COVID. the other criticity is that we don't really know. We know very little about the response to COVID patients to general anesthesia for surgical intervention. We had a lot of cases, and more we have cases of fatal pneumonia, even for positive asymptomatic patients that undergo general anesthesia for neurosurgery. And also because we don't really have anesthetic protocols, dedicated anesthetic protocols for COVID patients, even for asymptomatic patients. Obviously, the other criticities are the ICU bed shortage, and in this very difficult situation, older patients are not resuscitated. And patients that undergo brain surgery, they get extubated in the operating room and go straight in the ward. They don't go to the ICU anymore. Another difficulty, but we are putting up with this difficulty very well, is to work in an unfamiliar environment. But thanks to our colleagues, the orthopedic surgeons, the vascular surgeon we are working with, we are putting up with this difficulty very well. The problem is there are a lot of flaws in the newly designed protocols. For example, this is a 43-year-old man, no past medical histories. He comes to the ER about 5:30 in the morning, a couple of days ago, with a sudden headache, vomiting, Glasgow 15. And obviously, he needed a CT scan. But one of the two CT scans in the ER building was needed a decontamination. He was actually, the CT scan was actually in the process of decontamination, because the other CT scan didn't have the possibility to have a decontamination because it wasn't possible to switch out to the air conditioning. So in the main ER building, there are two CT scans. One is dedicated just to diagnosed COVID patients, because it doesn't have the possibility to be decontaminated. The other one, which has the possibility to have the decontamination, because it is possible to switch out the air conditioning, was being decontaminated. And so the patient had to wait 2 hours to get a CT scan. This is the CT scan, fissure for a subarachnoid hemorrhage from a pica aneurysm. And during the CT scan, the patient became somnolent, agitated, and obviously we had to put an external ventricular drain. But where? There was no time for COVID test results. So we should, we considered to take him to the COVID OR, but the patient didn't have any COVID symptoms. So according to our protocol, if the patient in emergency comes and doesn't have any COVID symptoms, we should undertake surgery, urgent surgery, in the no COVID area. What we did is that it was a really high risk of contaminating the no COVID OR if the patient had, if the patient was COVID positive. So what we did is to do a CT scan, a chest CT scan. And we did well, because despite the fact that the patient was symptomatic, or at least was asymptomatic before becoming somnolent, the patient had a ground glass opacity, typical for the COVID. So we took him in the COVID OR to put an AVD. So these really what we have now is a new order, really upsetting, because the protocols we designed before really using these protocols have a lot of flaws. What we learn basically is that it is really illusory to think that a separation between COVID and no-COVID patient will last if in the same hospital there are COVID and no-COVID patients that are taken care by the same teams. It is not possible that this separation will last if anesthesiologists, surgeons, operative room nurses go and cross over the two sections. Really, to continue in our care of no-COVID patients, it is important, it is paramount, it is critical, a strict separation between COVID and no-COVID hospitals, not just section in the same hospital. What we are trying to do now is really to move our division of neurosurgery outside the hospital. We started asking the oncology networks to help us. But the problem of the oncology network is that they have just a consulting role. So what we found out is that the cardiac transplant network could help us, because the cardiac transplant network has assistential needs which are really similar to neurosurgery. And most of all, the good thing is that the director of the transplant network, which is a really pyramidal organization, is a medical doctor and has the discretionary power to accredit private structures for neurosurgery. So the next step is to move the neurosurgery division outside the hospital in a private structure which is accredited for cardiac transplant. The other thing that we learned is that in emergency, we should really consider to do a chest CT scan for each and any emergency patient, because the chest CT scan has a higher sensitivity and is really quicker than the test for the COVID virus. And it's also critical to design protocols for the decontamination of the CT scans, MRI, and also the ORs. It is crucial even when it is the time for acquiring CT scans machines, to consider the possibility to switch off and on the air conditioning very easily, because if the air conditioning is difficult to switch off, the decontamination is really problematic. I will finish my presentation with a sentence of one of my colleagues in Bergamo, which is really at the end of their resources. This outbreak is not just an intensive care phenomenon. This is a public health and a humanitarian crisis. And we really need a long-term plan for the next pandemic. And I'm finished with that. Naren?
Naren, we cannot hear you.
Any questions?
Naren, you're muted.
Sorry.
Naren, you're muted.
Yeah, no, I didn't hear any question.
Good. Can you hear me now?
Yes.
Great. Thank you. So I will start with I think Professor Dr. Rutka has a question for you, Francesco. Dr. Rutka, do you want to go ahead?
Sure. Yeah, thanks, Francesco. Thank you very much. And your experience is really helping all of us try to cope as best as possible with this pandemic. But I was just wondering, based on your presentation, obviously, so many of you are still working in the hospital system in Italy. How many either asymptomatic or mildly symptomatic healthcare personnel like nurses, surgeons, doctors are getting tested for COVID-19 as almost like a screening maybe each day or each week?
Yeah, well, what we are trying to do is to test any medical doctors and nurses that are working in a hospital. I mean, the priority is obviously people which are mildly symptomatic or people that have had a contact with a COVID positive colleague or patient. Me, myself, I did the test, the RT PCR test, because I had a contact, even if it was protected, with one of my colleagues. We have this kind of priority to test each and every one of us. That is, the problem is the shortage of tests. So we are going to, in next week, hopefully, we're going to be able to have the test with the immunoglobulins, not what we call the PC, the RT-PCR, but the immunoglobulin, which is quicker and is a first screening. Yeah.
Thanks.
Dr. Harbaugh, do you have any questions for Francesco?
No, just thank you for sharing all your experience. I think this has given us a lot of information to try to help plan before the wave hits here the way it's hit Italy. So thank you very much.
Yeah. What I really want to stress is that it is illusory if in the same area there is a section COVID or no COVID, this separation will not last. So really try to separate the hospitals, COVID and no COVID. And most of all, if a medical doctor or a nurse works in both sections, this will make the outburst grow. Because the hospital now is the main place where the pandemic grows.
But that insight came, unfortunately, rather late in the whole in the situation. So this is the lesson that other countries where it is just starting now should learn very early on. And that's the same here, that we have not done that. We have not separated them sufficiently, or not even, sometimes not at all. So I think this is very important also for, as you say, the long-term plan for the next pandemic. So thank you very much for this insightful presentation, Francesco.
My pleasure. Thank you.
That's great. Dr. Boop, I think your microphone is muted. But do you have any questions, Professor Salomao?
Yeah, this is a beautiful presentation, and it's given great insight into some of the problems that we have in planning for what's going to happen in the next several weeks here. How long does your decontamination process take? Is it several hours?
2 hours.
2 hours.
Yeah, 2 hours. Yeah, it's done with ammoniac and with I think with nitrous peroxide. Yeah.
Very good.
It takes no less than 2 hours. So if you have 2 CT scans there can be decontaminated in afternoons, it's good. If you have just one CT scan, you're in the trouble.
Thank you.
Constantin, do you have any questions, Constantin? Anyone else have any questions for the Professor from Professor Signorelli? Okay, so thank you very much, Francesco. That's really put the from the first hand, from the very cold face or very hot face. I'm just going to put a poll for you. I hope you can see it in a second, and we can get a quick answer as well. So you should, is a poll, can you see a poll appearing on your screen?
Yeah.
It just was there.
Oh, okay.
Now it is up again.
Yeah, it's okay.
So it's just 3 questions. What do you call, you can, it's all anonymous as far as I know, so you can.
Okay, fill it out.
Okay, I'll give it 10 seconds. George, do you have any questions for Francesco?
No, I thought that was an excellent presentation, and the world should learn from the lessons that you've just provided us about separating the COVID positive population.
Okay, so I'm going to close the poll in 5, 4, 3, 2, 1. Okay, it's closed. I'll just show you the results. You should be able to see the results. Has all the elective operations been cancelled in your hospital? Interestingly, not in 23%, not all of them are cancelled in 1/4. Are you doing telephone clinics? Most 82% of here we have those who answered the polls here. So that's here, 22 people have answered it. 82% are doing telephone polls. And is your residents working in other departments? So 18%, so that's 1 in 5 is currently working in other departments.
Okay.
So that just sets the scene again. So thank you very much again, Francesco. I'm now going to move to Professor Dr. Harbaugh. Let me just close this. Dr. Harbaugh, I'll just get your.
I'll hit share.
Yes, please, if you try.
It says host disabled, attendee screen sharing. So.
Okay, I'll just make you host. There you go. You should be able to do it now. Thanks. Brian.
You see the
Excellent.
presentation?
Excellent. It looks great. Yeah.
Yeah.
Okay, so thank you, Naren, for arranging this. I think this is important for everyone. And I'm going to give you a little different perspective. Not allowing me to advance. There we go. So, you know, what we did starting about a month ago, before we had any COVID cases, was to create a couple of incident command centers. And those were to coordinate both planning and response to the epidemic. One was for our academic medical center. And in my role as the senior vice president for our academic medical group, I had a leadership role in that. And then one was for our health system. And so I represent our academic medical center to the health system. So this is really not something I was trained to do. It's on the job training. I've learned a lot about, you know, the planning in response for something like this. But it's interesting to me that almost everybody who's been involved with this this isn't what they've been trained to do. They've been trained to be physicians, surgeons, nurses, hospital administrators, et cetera, et cetera. So this is one of the things we did early on that I think has been very helpful is we set up specialty specific teams to plan for what we were going to do contingency planning. Probably the most important were COVID treatment teams, and I'll talk a little bit about that later on. But we also set up specific teams for surgery, primary care, hospitalists, intensivists, and others as needed, so that people would say, okay, for surgery, how are we going to plan so that we stay one step ahead of the curve as the number of COVID cases increases? And I'll talk a little bit about that as we go on. So some of the issues that we've been dealing with. I mean, we've all heard about flattening the curve, and I think the message from Italy and elsewhere is there's very little we can do. Naren, okay.
Dr. Harbaugh, I think Dr. Rutka can't see your slides. Has anyone else have problem with seeing the slides? Dr. Boop, can you see the slides of Dr. Harbaugh?
They're showing up just fine for me. I don't have any trouble seeing them.
Okay. Dr. Rutka, it might be just that the Zoom has, if you go to the window, there's another window below it. There are sometimes two windows open up. It might be that, sorry, Dr. Harbaugh, you can carry on.
Okay, so I mean, we've all heard about flattening the curve, and I think as we found from other countries, this virus is very transmissible. There's nothing that we're going to do that will completely isolate it, certainly not in a country like the United States. And really flattening the curve is sort of slowing the surge of cases so our health systems aren't overwhelmed. And these are primarily public health issues. So in Pennsylvania, I think our governor has responded well. He's closed the schools, closed non-essential businesses. When the number of COVID cases in a given county hits a certain point, he'll lock down travel. And so again, the idea is just to slow this progression so that at no point do the healthcare systems get overwhelmed. When we started preparing for our surge, one of the things that we recognized early on was going to be difficult would be to acquire and preserve personal protective equipment, masks, face shields, gloves, gowns. The demand for those really outstrips the supply in the United States and around the world. And so, some of the things we did as far as tiering our surgical cases, making sure that we didn't have, double scrubbing, so as much as we wanted to make sure we continued our training of the residents, we started doing our cases without the residents being scrubbed whenever we could, simply to preserve, this personal protective equipment. We also wanted to make sure we preserve capacity for inpatient care. So we had a surge plan in place for how we managed all of our ICU beds, all of our negative pressure rooms, ventilators, ECMO capability. From the surgical standpoint, we had a tiered plan for surgical cases. And so actually we started at tier 1 before we had our first COVID patient. And he said, we know this is coming. We're going to avoid patients at increased risk of exposure. So any patient who was scheduled for an elective operation, who was advanced age, immunocompromised, pulmonary or cardiac issues that would put them at advanced risk, who could safely have their surgery delayed, we just rescheduled those patients for 2 months later. And actually the patients were quite happy that we had taken that into consideration. We're now at tier 2. So we have patients, if they will be adversely affected by a 2-month delay, even though they are officially elective cases, they can still be done. On the other hand, if a patient will not be adversely affected by a 2-month delay, then those cases again are postponed for a couple of months. And I must say the cooperation of all of the surgical departments in doing this has been dramatic. We've really cut our elective cases down very effectively. And then at some point, we will go to tier 3, where we do only urgent or emergency cases. And we assess on a daily basis our supply chain issues, ICU beds, number of COVID patients, et cetera, et cetera. So we know when to pull the trigger on moving to tier 3. Sorry, I'm having a hard time.
I'm moving the slides.
Advancing.
If you just click on the escape button, and then it will become.
I tried that.
You have. If you just. Okay. Oh, good. It's come.
Okay, so the next thing is reducing patient and provider exposure. And as has been discussed, I think that this is a huge piece of what we have to do, because we don't want the hospital to become the source of dispersion of the virus. So before we had our first case, we started travel restrictions. So patients who or faculty and other employees who were coming back from international travel, who were coming back from high COVID areas, initially places like Seattle, were put on a 14-day home quarantine before they could come back to work. And those travel restrictions have changed and become more stringent, sort of week by week. We also started using a lot more telehealth and telephone consultations, and we're actually up over 50% of our clinic consultations now are done remotely. I noted that we rescheduled elective operations. We started telecommuting for much of our office staff, schedulers, administrative personnel. This week, we instituted a no visitor policy for both the hospital and the clinic, so that didn't have family members accompanying patients to the hospital or the clinic, unless it was a child who could have one person or somebody who was incompetent to give consent or otherwise disabled, they could have one person. And I think the travel restrictions and quarantine policy and social distancing throughout the institutions has been very helpful. I mean, we changed our cafeteria, so the chairs, were 6 feet apart. So we've done a lot, I think, to sort of slow the spread. We started patient screening early, and we tried to do all of this screening outside of the buildings. We set up a tent for our emergency department patients to be screened. A standard protocol was used to determine the need for testing via an app that anyone with a cell phone could use. So if they went through the steps on the app and it said they needed to be tested, they could show up at an outside drive-through testing site. They've already been registered, et cetera, et cetera. And so we didn't have to expose people to the folks who were just there to be tested. Initially, our testing had to either go through our State Department of Health or a commercial lab, Quest. Both were rather slow. The Department of Health had very stringent criteria for who could be tested. Now we have on-site testing, so we'll be able to expand that testing for some other indications. And what we found were there a number of COVID-19 positive patients who are well, and those patients do not come in the hospital. They get home quarantine. They take their temperatures twice a day. They have a symptom checklist. And for some, we've given them a pulse ox to use. And that's, again, worked well in keeping as many COVID positive patients as we can outside of the hospital. This week, we're starting employee screening. Communication for that is the key. We've been sending out messages all weekend. And the message is first to self-screen. Do not come to work if you have a fever or any of the symptoms on a checklist we send out. New cough, new muscle aches, throat pain, shortness of breath. Just don't come to work because you're going to get screened out anyway. If they have any of these things, they inform their supervisor and our employee health group, and then they go take it from there as far as follow-up and screening of these patients. We've also limited the number of entrances to our academic medical center campus. We found there were more than 40 entrances where people could come in either to our College of Medicine or to the medical center hospital. And we've reduced those to 10 so that we can have screening at all of those entrances. And then another thing that was, it takes a crisis to do this. We removed all parking restrictions. So the people can park wherever it's most convenient to get to one of these sites. This was brought out in the previous presentation, but I think if we want to reduce patient and provider exposure, we really need to limit the number of COVID treatment sites. And we've done that, I think, pretty well. We have a number of negative pressure rooms that are throughout our ICUs. So we thought was when we were up to 4 patients, we could put these patients in a negative pressure room so that we reduce the chance of contamination. And work them up there. If they're under investigation or COVID positive, they can be treated there. As soon as we went past 4 patients, we then converted our pediatric emergency department to a negative pressure unit that could take care of up to 10 ICU level COVID patients. So, we could co-localize, cohort those patients in one site. We've now moved to the next site, which is our surgical intensive care unit. So the COVID patients now will all go either in this pediatric ED or in the surgical intensive care unit. And the patients that had been in the surgical intensive care unit have now gone to either the neurointensive care unit or the heart and vascular intensive care unit. And because we've cut down on our elective cases, we've been able to accommodate them. If we go past 40 patients, we have plans to use our ORs as we have negative pressure ORs that may have to get converted to ICU rooms. Our anatomy lab can be converted to a negative pressure environment, and that could probably hold as many as 20 patients. And we have plans for a medical tent that will be completely outside the building if the surge goes to that point. We also set up an outpatient site for COVID-19 positive patients. This is clinic, lab, imaging. It's on our campus. It's on the west side of our campus. It's outside of everything else, so it is separate. And another important thing is we do have COVID-19 treatment teams that include hospitalists, intensivists, ID physicians, nurses, respiratory techs. They have a regular schedule. They're the people who are going to be caring for the COVID positive patients. And we have a ramp up plan in place. Eventually, we have two neurosurgeon neurointensivists. Eventually, they may get called in to be part of these COVID treatment teams, but they're on the last tier. Some of our residents are critical care trained. They will also get pulled in as necessary. But again, it depends on how many patients and what we need to do to meet the surge. So I think that we've done a pretty good job of preparing for this. We've taken some of the lessons from China and Europe, and we'll see if we can stay ahead of the curve, and happy to take any questions.
Thank you very much. I'll just make sure. Yeah, thank you very much, Dr. Harbaugh, for the systematic measures that you have taken. I'm just going to ask Dr. Rutka. Let me make sure that, Dr. Rutka, do you want to ask Dr. Harbaugh a question, please?
Sure. Thanks, Bob, and good morning. And it's amazing to see what you've been able to bring to bear at your institution in Pennsylvania. So just wondered, is there uniform agreement as to the cases that surgeons would book as either urgent or emergent cases? And is there any issue with limited resources and surgeons wanting to get cases done? Who decides, who has the authority to decide which cases will go forward and which ones really could wait a bit? Sometimes this turns out to be, as you can imagine, an issue at some of the institutions.
So we have a 3-person review group. It's an anesthesiologist, myself, and a paediatric surgeon. The process is, if there's a case booked that looks at all questionable, then the anesthesiologist sends an email to that surgeon and says, is this something that really has to be done? They will send back their explanation. For instance, we had a spine case on last week, and he said, do you really need that? But it turns out the patient had a progressive myelopathy, and delaying that for 2 months, we thought put that patient at significant risk. So that was allowed to go. There were some other spine patients on where it was, sort of chronic pain symptoms that were reasonably well controlled. Those got delayed. But this 3-person group reviews all the cases, and so far we have had no fight about that. If the decision is this shouldn't happen now, it should be delayed, everybody's going along with it.
Great, thanks.
Dr. Boop, I'll just, Dr. Boop, do you want to?
Yeah.
Please, thanks.
Bob, one of the things that we're hearing from New Orleans and New York, places that have a high volume, and Francesco, I'd love to hear your thoughts on this, is that they've run out of propofol, they've run out of Versed, they've run out of fentanyl, and they're having trouble keeping stocks of essential critical care drugs in the pharmacy. Is your pharmacy stockpiling, or how are you preparing for that eventuality?
Yeah, so I mean, we have a supply chain update twice a day, and it looks at not only the drugs and ventilators and ICU beds, but masks and face shields and gowns. And so far, we've been able to stay ahead of the curve on all of those things. We've had a remarkable community response. I mean, there's a local distillery that switched over to making sanitizer. Smells a little bit like gin, but that's okay with me. There's a group of Amish ladies who are sewing, face masks like mad. We've had another local factory that switched over to making face shields. And so we've had a very good local response from people in the area to, help with a lot of the equipment. So our supplies are stable. And then we've tried to limit the exposure so that we don't have to give every person in the hospital, an N95 mask. So we're keeping those for higher risk procedures. So the people who are doing an intubation, anytime there's a risk of aerosolization, upper airway procedures from ENT, upper GI procedures, from our GI docs, intubations and extubations, those people have a much higher level of protection than people who are just taking care of the routine patients that come to the clinic or are on the hospital ward. So we're trying to do this in a way that saves the high level protection for people who really need it. And so we don't end up being behind the curve as the number of patients has ramped up.
Professor Grotenhuis, can I please get you to make any comments, please? Thanks.
Well, thank you, Bob, for such a nice presentation. And what I see, there was a kind of military plan that you rolled out, and I think that's necessary, of course. Is this what you have displayed representative for the rest of the US?
I don't know. I think there are places where, this varies from hospital to hospital and health system to health system. And, one plus for us was, we saw what was happening in China and Europe and then New York. And so we had a little more time, as this spreads. And I think the thing that I feel most positive about is everybody in our organization has really pitched in. We've had, really almost no pushback on this. And, they realize this surge is coming. We're not overwhelmed, but we've seen our, inpatient numbers steadily increase, and we're hoping we can stay ahead of the curve.
Well, and I very much like also the question from Jim, that because that is different in all the places, how the triage is really done. I mean, now the triage of all other patients, the non-COVID patients, as we see in our hospital, it is in a centralized, and it's in many other hospitals here too, it's a kind of committee deciding this, and there is not always a neurosurgeon being part of it. Of course, if there is a neurosurgical issue, they will say, okay, you get 4 hours of OR time tomorrow, but you have to make the decision then, which of these 6 patients will be your choice. And that's indeed between a 4-centimeter cerebellum metastasis and a cervical myelopathy, and then a child with a brain tumor, hydrocephalus. So that's hard, because you only can do that. And for you, I see that you are still having more or less your own kind of triage within neurosurgery. But at one point, and I think in Italy there was the same, at one point, it just has to be centralized because the overwhelming numbers. So maybe Francesco can give a comment to that. Thank you.
Yeah. Yes, actually, we discussed with our colleagues. It's easier for now because we are really gathered together in the same building, and the criteria is that for oncologic patients, for example, if there is no good alternative except surgery, well, this is a criterion. What we do is no more, obviously, skull-based meningiomas, mostly metastases, glioblastomas. Obviously, the thing is, be able to count on ICU places. For example, if I have I had a 4-year girl medulloblastoma, which had to be operated on, but I prefer to operate her one day later because I didn't have any ICU place when I first saw her. Mm-hmm. So it is important also to see if the ICU bed is available or not. The other thing is transnasal surgery.
Oh, yes, yes.
We don't do it anymore. Mm-hmm. We have stopped that. Pituitary tumors, or anyway, tumors that could have been approached through the nose endoscopically. Now we are doing that transcranially.
Really? So you fully have changed that. I mean, there is a very high risk, as we know from the Stanford protocol, that when they send this out. So you would now indeed do a craniotomy to, let's say, for somebody turning on, having visual problems, and okay, wow.
It's too risky, and we should do that with the whole staff. And I try to operate with a microscope, with the whole protection is just not possible.
Wow.
One of the things we did early on was ask our surgery department chairs to submit a list of cases that they thought were usually able to be delayed. So everybody did that. So we had a good list to work with. And we let the chairs know the principles of how we were dealing with this. You know, tier 2 is if the patient will suffer irreversible harm, you can go ahead and do it. If they can safely be delayed, delay it. And I'm going to say the chairs have worked well to make sure that their faculty adhere to that. Every day we have, a handful of cases that are questionable. And when we go to the individual surgeons, they can either explain why this one really should go, or they're very cooperative and say, no, okay, I'll postpone that.
Wow.
Great, thanks. I'm just going to now, Professor Wagner, do you want to ask a question,
yes,
please?
Just one short question to Bob. Excellent presentation. And this is a question to you and also to others. Have your local or your national scientific surgical societies or neurosurgical societies defined cases that are elective and can be postponed, and other cases that should be operated on even during the present pandemic?
I have
like
not
in
seen
Germany, because in Germany they have.
Yes, yeah, I know. Therefore, I asked this question. Yeah.
Yeah.
I've not seen that from our national.
Okay. Thanks.
And also not in the Netherlands. No, not yet.
Next question is from Dr. Konstantin Slavin. Konstantin, I'll just get your, is your mic still, let me just see. While I'm sorting the mic of Dr. Slavin, Dr. Boop, do you want to ask your question, please? Thanks.
Yeah, Bob, just a question about outpatient surgery centers. In our area, a lot of neurosurgery, elective neurosurgery is done in outpatient surgery centers, particularly spine, ACDFs, lumbar discs, T-lifts, peripheral nerve surgery. And we're also, to conserve resources, doing emergencies there, but there's the feeling that because patients don't have to go to the hospital and they go home after their surgery, that may be a safer location for a lot of urgent neurosurgery, hot radiculopathy, myelopathy, things like that. Comments?
Yeah. We've done the same thing with our outpatient surgery center. We ask that they adhere to the same criteria as the inpatient operating room, so that we are, conserving the protective gear, et cetera. And so if they have an urgent case that they can do at our outpatient surgery center, that's been encouraged. But what we've seen is a drop off in the number of cases at the outpatient surgery center. It's very similar to what we've seen in the inpatient setting.
Dr. Rutka, you wanted to make a comment, Dr. Rutka?
Yeah, thanks. I think it was Dr. Wagner who asked about national organizations that have stipulated which procedures could be postponed and which ones are true urgent or emergent cases. So, the American College of Surgeons has developed criteria for this. They're published. Most of them deal with surgical disciplines outside of neurosurgery. I've not seen for neurosurgery yet, but for a lot of like the vascular general surgery types of cases, those are on mine. Now, the problem with that is, the final authority over what cases will go at any institution really rests with the hospital or the institution, but these serve as guidelines. And if you're interested, you can go to the American College of Surgeons website to see that.
Thank you. Konstantin, your mic should be able to.
Thank you very much. Can you hear me? The great presentations. I mean, we obviously have the same type of setup as Dr. Harbaugh mentioned, with significant reduction of general surgical activities, but the elective surgeries are completely out of picture, and the difference in our place with Italy is that we have everything in one building, so we just try to separate by floors, and certain floors are dedicated to COVID and certain are not. And so I had a question, Dr. Signorelli, and I wondered, is there any difference in the case mix among COVID patients? I mean, we pretty much well prepared to take care of regular neurosurgical issues, but do they have anything different? There's a lot of conversation about neurological involvement with COVID, but is there anything neurosurgical that we need to prepare for?
Yeah, as I said, can you hear me? Yeah.
Yep.
Okay. So as I said, even asymptomatic COVID positive patients, they are at risk of developing after general anesthesia fatal pneumonia. What we need is anesthetic protocols. We don't really have anesthetic protocols for this kind of patients, even asymptomatic COVID positive patients. What I think is all COVID patients should have an ICU bed after surgery. But then I don't really have any solution. I don't have any real clue in order to prevent the pneumonia complications for this kind of patient. What I know is that they are a high risk of post-operative pneumonia, even if they are asymptomatic before.
Wow.
Thank you.
It's very, very, very worrying.
Can I ask Zulma? Zulma, do you have a question?
Yes, good morning and good afternoon, everybody. Thank you for doing this. One of the questions that are more worrisome to us as we prepare for the peak, we already have cases locally, but as we prepare for the peak, is related to Dr. Rotka's questions to Francesco early about what happens when the medical personnel, so the healthcare practitioners, are tested positive, even if they have mild or no symptoms. When are they allowed to come back to the hospital to practice?
In a hospital, when a medical personnel in general, even if is asymptomatic, is positive, they are in quarantine for 14 days. They have to repeat the tampon, the test, before coming back. And if they are still positive, other 2 weeks. And even if they are completely asymptomatic, they're not allowed to come back to work.
And that's worrisome in our area because the Department of Health protocol says that medical personnel that is in these circumstances have to go to work at 7 days after. So that's why the question is raised.
All right.
That's the US system. Is Dr. Salah still there? Dr. Salah? Okay. Before we move to, I'm sure if Dr. Salah comes back, then I'll put him back on. He has been waiting. Just a small question, Dr. Harbaugh, you mentioned about hand-stitched masks. Dr. Kathy Beecham from Denver was asking, in which places are that allowed to wear? And I've got a small poll as well. So while Dr. Harbaugh is answering, I'll just put the poll up as well. So in which places is the handmade mask allowed to be used? Thanks.
Yeah, so that's a very good question. And so what we've tried to do is look at, one, are the handmade masks, the cloth masks, effective? And I think the honest answer is nobody knows. There is a psychological piece to this. And one of the complaints that we had heard from our nurses, for instance, was that we weren't taking their health seriously enough because we didn't give a mask to everybody every shift. And the problem is, if you're trying to preserve things for a surge, you really don't want to be handing out masks to every caregiver every shift when they're caring for low-risk patients and their risk of exposure is actually low. So we've got a plan that we're going to enact actually this week. We're trialing some handmade masks that we had made that we're going to suggest can be used over top of a regular surgical mask to keep it clean, so that you can use that surgical mask for a week. So you have, they'll have their own handmade mask plus a standard surgical mask. They can put that into a plastic bag. They keep that with them, that's theirs. And I think that's going to help make people feel better that they're getting some kind of protection without decimating the stores of protective equipment that we may well need in a couple of weeks.
That's brilliant. I've got a question from Ted. In terms of re-sterilizing masks, are they happening, any of these masks being re-sterilized? I presume those masks are thrown away after use in terms of
We have protocols for re-sterilizing the N95 masks, and we're developing new ones. So we think that those masks can probably be used for 5 or 6 times safely and still be protective if the re-sterilization is done appropriately. And we're looking at all kinds of things for re-sterilization, including UVB light, other types of radiation. So that's all being developed on the fly.
Thank you. The last question is for Dr. Harbaugh, is from Dr. Salah Beisa. He's from Saudi Arabia. Dr. Salah, please go ahead.
Hello, do you hear me?
Yes, yes.
First of all, thank you very much for sharing your experience here in Saudi Arabia. We're facing this problem, but we sort of felt that we're ahead of the curve in our precaution measure. In my hospital, we're having weekly shifts where the neurosurgical team take like a week care of the patients, and we do online meetings with the next team and handing over. we have a few cases, not like what's been reported in other countries nearby or Europe or US. So we felt that with our resources so far, we're good. We're taking all this measure, by the way. I just had a question about, because we're working in university and over the last month, we had a lot of medical students helping in caring those patients. We had few medical students involved in getting COVID-19, so we stopped. So is there any special precaution for medical students in the hospital, university-based institutions?
Yeah, so a couple of things. One, we've done the same thing with our residents. There are now 2 teams. And so the idea was we didn't want all of the neurosurgery residents to come down with COVID positive testing and have to be in quarantine. So they're split into 2 teams and they shift weeks. In regard to the medical students, our legal department said we cannot put the medical students at risk. So they're not allowed to participate in patient care or screening of employees during this, but we've tried to use them for doing non-risk things like, contacting patients via telephone, doing every 2 days we get a new update on all of the latest information from the web that's collated and organized by a medical student group. And the frustration is the students really want to participate. They really want to do something. And we've had to tell them, leave the College of Medicine, don't come in, work from home. They're getting, their education, lectures and such via a Zoom, but they're really off the campus.
That's brilliant. Thank you very much, Dr. Harbaugh. I'm just going to now get Dr. Rutka to share his presentation. I will just a second. It's like closing a circle, because it was back in 2005 that Dr. Rutka kindly introduced me to Dr. Harbaugh, because at that time I was trying to organize an electronic conference. So it's really nice that, and I did, but it used to be with the PowerPoint on the web, but it's nice that we have come all the way back where we started. Dr. Rutka, are you still there?
I'm here. I just can't seem to share. It seems to be controlled by you.
Okay, just a second. You are under the name surgery, aren't you?
Yeah.
I'll just see where you are. Good. You should be able to now share.
Okay, I'll try. Yeah, here we go.
Brilliant. Thank you.
Okay, can everyone see my screen?
Yep.
Okay, great. So yeah, Naren, thanks very much. It's really an amazing thing that you've done today to pull us all together to share experience and best practices with how this pandemic is affecting all of us across the world. And you've asked me specifically to speak a little bit about the impact on pediatric neurosurgery. So I'll do that today, and I'll also move into a little bit of perspective from the University of Toronto, both from pediatric and adult experience, and then talk a little bit about how we can share information rapidly, obviously through devices like social media, but even in rapid communication online formats. So what's really interesting is the fact that if you look at COVID-19, there were no publications on this really before December. And then in just a matter of 3 or 4 months, if you look at what's instituted across the world now, there have been over 1,500 peer-reviewed publications on COVID-19. And they affected a variety of areas. Of course, at first, the infectious disease aspect, the identification of the genome of the virus, and all aspects related to critical care medicine, the pneumonia process, but then it's kind of spilled over now to almost every specialty and specialty group in medicine. Well, what about COVID-19 in children? And it is fair to say that on average, the disease may be a little less severe and occurs perhaps a little less often, but it does occur for sure. And experience from China has taught us that on the epidemiology of COVID-19. And you can see on the bottom of the conclusions there that all age groups of children are affected by COVID-19 in no specific gender difference, and that this is important for all of us to remember. Here's a publication on the clinical features of severe pediatric cases. So as mentioned, it can happen, it can be very severe in some groups, and this is the experience from Wuhan, where they described the severe cases that can occur even in the pediatric population. So the data for my presentation is really taken from my personal experience at one of the largest institutions for pediatric care in North America, but also perhaps throughout the world. Through work that we're doing at the University of Toronto in all disciplines of surgery. I've asked the groups that deal specifically with pediatric care, like the American Society of Pediatric Neurosurgery, its leadership. I'll talk a little bit about a response from the International Society of Pediatric Neurosurgery. We've made inquiries of the editorial board of the Journal of Neurosurgery Pediatrics, and global inquiry soon to be published, as mentioned earlier, on rapid communication editorials that will appear in the Journal of Neurosurgery. Well, what is happening at Sick Kids Hospital in Toronto since March, mid-March? We've had a reduction of throughput in surgery so that only emergency pediatric neurosurgery procedures are performed. And as discussed, we've been able to prioritize these and put all non-urgent cases on a postponement list for later. So essentially for us, as you know, we deal a lot with urgent cases in pediatric neurosurgery, just as in adult neurosurgery. This comes down to neural trauma cases, hydrocephalus shunt cases, certain congenital cases as listed here that need to be done, tumors, a variety of different types of tumors, but primarily where the suspicion is that it's a malignant tumor and where delay in care of the child will make a big difference. These are very important for us to categorize and prioritize. Vascular malformations, intracerebral hemorrhage, and so on. These are all considered to be urgent cases. So I hope my colleagues on the phone would agree with that. And then in terms of cases that are not urgent to think about, listing them all here: epilepsy, of which there's a variety of different types of cases, different types of spinal conditions, craniofacial, laser type cases. All these things, functional, are basically not being performed at this time and will not be for the foreseeable future as our surge of COVID-19 cases is increasing. And where we make it possible now, we're limiting the number of care providers. That includes anesthesiologists, nurses, the surgical team. All those numbers are being reduced in the operating room anytime. And I'm not sure it's been mentioned yet, but one of the highest risk procedures to be done in any hospital at any time with COVID-19 is intubation and extubation. It's like 6 times higher than almost any exposure of any surgical procedure. So at this time, our anesthesiologists are doing the intubation and extubation pretty much by themselves in the room. The treating team is out of the room when the anesthesiologists are involved in care. And they're fully protected with barrier protection as they're doing this. And of course, this has implications for us as after that's done for strict gowning and barrier protection protocols for us, and patient handling and positioning are all done with certain degree of care. Now, from the University of Toronto experience, you may remember in 2003, SARS became an epidemic. We had considerable experience with SARS in Toronto. Toronto was one of the hardest hit cities in the world at that time, largely because of international travel and the fact that a lot of individuals arrived in Toronto carrying the disease. So we had some experience in the background on how to deal with this, but I must say COVID is far more pervasive and infectious to a degree, and it's affecting, of course, more individuals. So we are not, I don't think any of us, fully prepared as we could be, which is very interesting perspective when you think about the next pandemic. I think we've all learned from this one in preparation for future type cases. So in the University of Toronto, we have 10 clinical departments. Medicine and surgery are the largest. We have 6 fully affiliated and 4 partially affiliated hospital systems. We have a single healthcare payer system, and we're provincially organized. And I'm sure with all of you on a daily basis, we're getting information from the university, the hospitals, the City of Toronto, the province of Ontario, our country, and then the news feeds from all around the world. So to be honest, many individuals are feeling super saturated with information now, and it's hard to put into perspective what's really important as the surge is increasing and continuing, because this information and the rules, at least where we are changing daily. I think it's very important for us to remember that our residents and fellows are particularly on the front line. So anything we can do to reach out to them and to support them and to help them in this process is very important. And we're putting systems in place, as I'm sure you all are, to mitigate against too many residents and fellows on a service at any given time, given the likelihood of exposures, the possibility of infectious transmission, and then having members of the team become either exposed or ill and having to take time away, and then depleting the number of individuals involved in the manpower of our cases. So we're just now in the circumstance of redeployment. That's probably worth a little bit of discussion, where surgeons, neurosurgeons in particular, neurosurgery residents and fellows are being asked in particular to consider covering services with which they have familiarity, like trauma and intensive care, critical care, and so on, where they've previously been able to do rotations in these areas and be available for that. We have centralized COVID-19 testing across the city, and also all hospitals now can test for COVID-19. And so our testing abilities, I think, have so far been able to keep pace with the demand, but that may not be the case in the future. So as chair of the University of Toronto's Department of Surgery, we're involved in coordinating the care across all the hospitals. I have almost daily correspondence with the surgeons and chiefs, including at Sick Kids Hospital, for sharing best practices. We're doing cross-credentialing of all of our surgeons to work at any of the University of Toronto hospitals in case there's a manpower issue with one of the divisions that goes down because of illness or exposure. Individuals from other hospitals will be able to come and immediately be able to help out, which has been very important. Our research laboratories for investigative studies, those have all closed down now at the university. I wonder if that's the case across Europe, other places in North America. And so we have residents who are involved in research in many of our programs. They're being called back onto the neurosurgical service, including the pediatric neurosurgery service. And redeployment for all of us, residents, fellows, and faculty, is underway within all the surgical disciplines. There's some downstream effects that I'll just mention briefly. We have an exam process that typically takes place in the spring by the Royal College. That's on postponement, so individuals who are finishing their residency will not be able to take their exams, as one small issue. Fellowships after residency, it's uncertain what will happen with them, given the fact that completion of residency may not be performed. And then individuals who are about to start their practices in neurosurgery, pediatric neurosurgery and adult neurosurgery, it remains unknown what will become of their startup dates down the road. Now, from the leadership of the American Society of Pediatric Neurosurgery, we've been able to glean the following, that restricted parent and family entrance to hospitals has now been undertaken at several sites. Definitely, as has been mentioned, common theme, shift to telemedicine, video conferencing, and so on. COVID-19 testing, what is optimal for pediatric neurosurgical cases. Team-based rotations on the ward and the ICU, minimizing numbers. Awareness of the strain on the adult facilities so that the pediatric services, which may be slightly less affected, may actually in the future be involved in the care of adult type cases, or at least distribution of equipment to adult facilities from the pediatric sites. Pediatric neurosurgeon redeployment is ongoing, and the depletion of the protection devices, as mentioned, is a threat everywhere as numbers escalate. I'm just going to take a moment to look at the chat line just to make sure that I'm not missing anything, and making sure that everybody can still hear me. Naren, can you still hear me?
Yes, absolutely. Yeah.
Okay, perfect. Okay, so I'll go on then to the next slide. Now, from the Journal of Neurosurgery Pediatric Editorial Board members who are neurosurgeons from across the country, the US, here's what we've been learning from them. Rationing of personal protective equipment for pediatric neurosurgeons is ongoing. Impact of the fellowship training. So in the American Society of Pediatric Neurosurgery, fellows are currently expected to complete a certain number of cases, but now that all elective cases have stopped, the question is, will many of the fellowship fellows, will they be able to reach the numbers that is anticipated for proceeding with the successful fellowship? I'm sure there'll be mitigating factors for that and contingency plans, but that's just something that's downstream. Nurses, nurse practitioner, physician assistants, we must not forget the fact that they're very obviously affected by and impacted by what's going on with COVID-19 in the pediatric hospitals. Many of the pediatric services are attached to an adult hospital, and there's cross flow between adult and pediatric sites. Not every hospital has, or not every university has designated standalone freestanding structures for pediatric neurosurgery. Each institution is prioritizing cases, and there's been fairly uniform agreement so far on what constitutes a pediatric neurosurgery emergency case. Everyone's preparing for the coming surge now in North America and trying to determine optimum management of the backlog down in the future, because this will be critically important. Something that hasn't been discussed yet, but this group, the editorial board members, brought up was the financial impact on all healthcare providers, not just surgeons, but in essence, all aspects of the hospital itself. And then coverage of the service in the event of illness and or quarantine. What will be happening in the event that one or more faculty members, residents, fellows go down in a site that's got a small number of bodies working? What impact will that have across the way? So then, and finally, Naren, what I think I'll do in just wrapping things up is talking a little bit about shared experiences from around the world that are coming forward to us now as we prepare to disseminate this information. As was mentioned by a number of individuals on the line already, we're all learning from one another's experience from very hard hit areas of the world. Jurisdictions like China, South Korea, Iran, Italy really provide insights to all of us as to what we can expect in regions that are just now beginning to feel the surge. So I've mentioned earlier that obviously we have news reports, newspapers, social media, etc., for rapid communications. But even in this time, we're very fortunate that many of our journals are able to come forward with rapid online communications. So we've now reached out to and have had agreement that we'll be publishing a number of rapid communication next month. So in the matter of about a week or so, the following types of editorials for all of us to learn from. So the experience from China has already been accepted for publication. Italy's experience, and you heard today from Francesco, but from Northern Italy, from Milan, Franco Cervide and colleagues have already had a paper accepted for publication. Many of you know that the annual meeting of the American Association of Neurological Surgeons was canceled. Not the first time in history, as I think the meeting was canceled in the war years in World War II. However, this really created all sorts of issues for a national organization like the AANS. And so Chris Shaffrey, who's the current president of the AANS, and Kathleen Craig, who's the chief executive officer, are going to write an editorial on what this means for our national organizations. Aaron Cohen-Goodell is going to talk about innovations in surgical education, even while we're not able to do our typical workload. What can we do to continue to improve our education and offerings for our residents, our fellows, medical students, and beyond? We're going to be publishing on academic training programs. Bob Carter, who's chair at Massachusetts General Hospital, will talk about its effect on academic programs. In North America, we have private practice neurosurgeons, and so we have a contribution from Adair Paul from Denver to speak about how that will affect smaller groups, what that means for them in terms of how they manage their practices. We have contributions from Singapore. Wan Chu Xiao will talk from the ISPN perspective. From South Korea, Sung-Gi Kim, who's chair of Seoul National University, who also happens to be a pediatric neurosurgeon, is presenting an editorial to us. Shared experiences from the editorial board members of the Journal of Neurosurgery, pediatric neurosurgery in the wake of COVID-19 from the ASPN leadership, members of the Journal of Neurosurgery Pediatrics editorial board will present their information to us. And then residency training program experience. I know George Jallo will be speaking about this, but impact on our residency is really important, and that will be also presented in the form of a editorial. So to conclude, from this presentation, I focused mostly on pediatrics, but gave you also some other perspectives. You know, the present and future impact of COVID-19 on pediatric neurosurgery patients has been discussed. Lessons learned from all jurisdictions are beneficial, and we should share these, and I mentioned ways in which this will be done. Some of you have been through the worst, so I think Italy is emerging as having gone through this. Of course, China has been through this, and they're sharing their experience with us, but for many of us, the worst is yet to come. I think in North America, this is the case. It's just about at that level right now. And I think there will be value as we go through this in revisiting the impact of COVID-19 on all of us once this pandemic is over, and doing an analysis of really how this pandemic has affected us, and trying to have lessons learned so that, as was mentioned earlier, that we can learn on how to prevent so much of this when the next pandemic strikes. And I think one thing is quite certain, that I think in a way, what China taught us was closing down as best as possible and as early as possible. Travel by airplane is likely one of the most effective ways in which this just must be contained. And this perhaps was done too slowly, but at least it was done. And at least in the future, if we can do things like that, and among other things, of course, as we prepare for rapid escalation of vaccine processes, novel drugs, ways in which we can share other types of novel treatments. There's discussion about immune convalescent serum and so on. All these things, I think, if they can be rapidly escalated to treat affected populations, all of those things will help us. So with that, Naren, I'll conclude. Again, I want to thank you for bringing us all together today. And I was happy to share this experience from our pediatric colleagues across North America and beyond, and be happy to take any questions.
Thank you.
That's great. Thank you very much, Dr. Rutka. It's very comprehensive, and certainly you have it's a great plan there. Dr. Boop, do you have any observations while Dr. Jallo, do you want to upload your presentation? Anyone else who wants to make any comments, please? Thanks.
I think everyone was overwhelmed already by the information we received, but what I saw is that most are, at least now in the Northern America, so Canada and US, are so well prepared, at least seems so well prepared. Although in the news we receive different images, but I think the doctors are very well, and certainly the neurosurgeons are very well prepared to deal with it.
That's great. And in terms of, is there any reports as far as you know about reinfections? Is it if people have once, are they definitely they are immune to it if they survive it? Anything concrete on that either way?
No, nothing concrete. Mostly they say they will not be reinfected, but that's very preliminary. So we just have to see.
Great, thanks. So while Dr. Jallo is getting his presentation, just a small, another two questions from our delegates. One was whether any of the consultants have been sent to work in ER or ICU or in chest medicine. And also the other question is there now any age limit anywhere for the physician or neurosurgeon to work in the hospital because of the high risk of different age groups? If you could just answer that for me, please, if you can. You can see the poll? Yeah.
Oh no, I don't see the poll. I see the presentation from Dr. Jallo.
Oh, you don't see the poll. I'll relaunch it.
I somehow, no, I see now the whole list of participants. That's good.
Okay, good. Okay, just a second.
Please unmute Dr. Harbaugh.
Sure, I'll do
that. he's
Dr. Harbaugh, yep.
Sign that he already.
Yeah, we haven't had a reinfection, but we've had a couple of cases where the initial test was negative. The patient continued to be treated as though they had COVID because of their symptom complex and imaging findings, and then subsequent testing was positive. So a word of warning that an initial negative test does not mean with assurance that that patient is COVID negative. And I think, like any test, there are false positives and false negatives, and we have to keep that in mind.
Brilliant. Thank you. Thank you very much. Thank you very much again to Dr. Rutka. And if there's any more questions to any of the speakers from before, please send it through the chat to me and I'll put it to them. Dr. Jallo, have you been able to upload the?
I'm ready. I'm ready to share my
oh, fantastic.
screen.
Great. Please,
Okay.
We are ready for you now.
Okay, great. Good morning, good afternoon. Thank you, Naren, for hosting this. I think this may be the new norm for us going forward. But just as many have said about COVID and the impact on organized neurosurgery, just a couple background slides. I think we have to look that it really started in mid-December of 2019, and here we are about 3 months later, and the entire world is affected by this virus. The latest I've heard is that I think there have been 2 strains. I did read a paper this morning that there might be up to 8 different strains of this virus, and there are some heat maps of people treating, trying to identify where the virus is coming into their port or into their city. This is from our Hopkins website, looking at the total number of cases, and this was yesterday. I think this morning it's up to closer to 700,000 confirmed cases, and again, confirmed is that they are tested and positive for COVID, and there are probably over, today there are over 30,000 deaths. In the United States, it's now, that was yesterday, today, there's about 125,000 confirmed cases and close to several thousand deaths, close to 3,000 deaths. And there it is in the UK. Again, it just keeps going up. And looking at the rate, how the countries are comparing, I think every country, some countries are doing a better job in containment, as has been discussed earlier. So what is the impact on residency, neurosurgery residency training programs? I think, when we look at this, every country, every region, every organization has almost addressed this in a different fashion. When you look at this in the UK and Europe, there's all residency rotations are paused or effective April 1st. And when we look at the board examinations, there's been cancellation of the board exam of the Royal College, as well as here in the United States. The written exam, which was scheduled for 2 weeks ago, March, I think it was March 20th, was canceled the day before the trainees were supposed to take their written examination in neurosurgery here in the United States. And the question is, what is the impact and what are the psychological aspects of canceling the tests to our trainees? And hopefully we'll learn a little more about that in one of the upcoming presentations. And I think, if you look at that, in the UK, all the colleges have decided all their exams, and there have been implications that there will be no disadvantages for missing the exam, and they'll continue to discuss options to when the trainees will be allowed to sit for this exam. And I think that's important. Even we've canceled the exams, but we really are uncertain as to when that exam will be rescheduled, or if it will be rescheduled, and the importance of canceling those exams, especially when you look at some of the requirements where the residents need to pass the written examination in the United States before they could finish up their residency program at the end of June. The other is when we talk about CMEs, the Continuing Medical Education Conferences and Symposiums. If you look around the world, in different organizations, not just neurosurgery, but plastic surgery, general surgery, internal medicine, even the CMEs, all external meetings and events, have been canceled until June 30th. And again, it is an ever so changing event that occurs day to day. Some organizations have delayed them or postponed them. Others have already rescheduled them to a future date, but these are uncertain times, so I'm not sure what that will bring. If we look at the annual medicine conference here, that was originally scheduled in Birmingham, has now been rescheduled till January of 2021. So some organizations are really looking forward and pushing the event. And when you do reschedule a meeting, what's the impact on the residency education at that time or today? When we look at the Accreditation Council CME programs, they had their conference that was scheduled for April has already been canceled, and they're looking at rescheduling that in terms of them. Looking for us in neurosurgery here at the AANS meeting that was scheduled for April 25th to 29th. There's a lot of discussion, but eventually that conference was canceled. And we do look at the educational impact to our trainees, but more importantly, for our trainees, the ones that are finishing or finishing their program or in their senior years, many of them use these CME programs as an opportunity to do job searches. And what does that mean for their job search, whether it be later this summer or next year when they're trying to solidify or look at opportunities across the country. The ESPN meeting, same thing. That was scheduled has already been rescheduled to July of 2020. And if we look at other international meetings, the 8th Federation of the Skull Base Society meeting scheduled for this weekend in Brazil. Again, that meeting has been canceled and rescheduled to December of 2020. Now, I look at this and again, more than just the educational value to our trainees, it's the networking that our trainees are missing out on. And will they have this opportunity in December of this year as it was moved? And then, your your international neurosurgery resident course, it was the 5th year that and it was being hosted in India, and that too had to be canceled given this pandemic environment that we are currently in. More other educational opportunities in the United States. There are the resident boot camps for the junior residents that are held at several centers across the United States on the East Coast and centrally, as well as the West Coast. Again, these are boot camps, 2 days of intense training for our junior residents, PGY2s and 3s, and as the original ones scheduled for April and May, all 3 have been canceled and will be a question of when will they be held will depend, and how will it affect the future courses and the attendance as they are required for their training program. Locally, I think there have been mandates placed by the individual institutions, whether it be the hospital, the university, or the organization. I can tell you at Hopkins, we are not allowed to have more than 10 participants in any room at any time, regardless of the agenda. And ideally, that no 2 people can sit within 6 feet of each other. So it makes it difficult sometimes to find a room to host the meeting, even to hold 10 people. All the neurosurgery grand rounds and conferences at Hopkins have now been converted, are web-based and conducted via Zoom. That would include the neurosurgery grand rounds, the morbidity and mortality conference that is being held for the residents as well as the faculty, to continue to provide education, yet it is the new norm of not being next to your resident or your faculty member during this. And the question comes, in terms of attendance, who, is it mandatory attendance or not, and how do you keep attendance? How do you ensure that the residents are, as well as the faculty, are participating, knowing that they are not in close proximity of one another? Another format for education at USF, University of South Florida, they've again canceled all their grand rounds and conferences with the residents. And in addition to their local conferences, they've gone to using a national library of conferences from the CNS and making this available to their residents. And, several points, this may not be the ideal time that was regularly scheduled for their individual conferences, but given the environment that we're in and the lack of operating, that it may be possible for all residents to participate in these conferences. Others, when we look at the outpatient, inpatient clinical volumes, our inpatient volume has been dramatically decreased given the restrictions that are placed on both the outpatient with telemedicine, and if we do allow the residents to conduct these telehealth interviews, how are they being supervised during this, and is there an opportunity? And then the operative case volumes, and we've heard a little about this. The operative case volumes will drop for all residents, and for some that are there, and for some residents that are rotating on pediatric neurosurgery service for several months, will they meet the minimum requirement as set by our national organizations? And if not, what modifications will be made, or do we have to allow them to spend additional months during their research years or during their non-elective years to acquire the minimally required cases? And I think, this came from the United States, the Surgeon General recommendation in mid-March, and every organization has taken it slightly different. I can tell you in the state of Florida, where the Children's Hospital is, it is an executive order from the governor of the state. And what we've, and I know, Bob, you've discussed it, discussing the procedures. For every procedure, we've got our tiered procedures, but every case that is being done in our operating rooms at the Children's Center needs this form to be completed at the time of the posting for justification why that is an emergent or an urgent case that needs to be completed that day. And this goes in that child's electronic record, so that in case it's ever reviewed, whether it be reviewed by a committee or by the government, they are aware why cases are being performed at our hospital. When looking at the organized ACGME, looking at the modifications that they've had to make and their adjustments that have been performed. When you look at that, in the United States, the Accreditation Council, Graduate Medical Education, you can see that accreditation, recognition, site visits, all in-person site visits of any residency program have been canceled. They are considering virtual site visits to be scheduled to clear the continuing learner education of residency programs. Those visits have also been suspended, and they're looking at when they will be resuming them, as well as some of the other meetings here as in this. Looking at the response from organized neurosurgery, the ACGME, really looking at the stages of the residency program, whether it's business as usual, increased clinical demands, or a pandemic emergency status, which overrides all the ACGME requirements. And then finally, just really, what do we do about medical student education? And this is really, the last slide that I will have. This was a message that was sent out from the university, and it was just sent out, I think on Wednesday. And given that, you know, as you can see, it's given the pandemic and ever rapidly changing, the School of Medicine to suspend all medical student clinical rotations. Originally, it was until April 12th of 2020, but you could see that they've extended it now to May 26th of 2020, so that there are no medical students that should be on clinical rotations on campus. Very similar to, I think, what Bob and others have said. You know, we're limiting the access of the medical students' exposure to this, and we've done the same thing with all our research laboratories have been shut down, again, to preserve supplies and limit the exposure and access to the school. So I think really, I think this pandemic has restructured education for all learners, whether it be consultants, fellows, residents, medical students. The clinical experience today is not what it was several months ago here in the United States. Research experience, you know, if you've got the residents that are on a one-year research rotation, they're being pulled out to do the clinical service. What are we going to do for them if this continues for several months and the unknown? What, you know, are we going to extend residency programs or not? Unlikely, but how do we make that up to our residents? And I think that, you know, Zoom, WebEx, Facebook Live may be the new educational norm. And, you know, again, what's going to happen with the hands-on experience for our residents? So with that, I will conclude. Thank you. Naren?
You need to unmute.
Yeah, great, thanks. So George, thank you very much for bringing to us very vividly what's the effect that's being happening on the training side. Obviously, that will come back and have a great impact. Dr. Rutka, you wanted to, can I ask you to make any comments or any questions for Dr. Jallo? Thanks.
Yeah, thanks, Naren. George, that's a great presentation, and it's quite clear that cancellation of all these meetings that you mentioned was absolutely the right thing to do. But I was just wondering, you know, are there any good solutions to hosting, you know, national meetings or information sessions involving hundreds or thousands of individuals online now? I know that, you know, you mentioned the web, Zoom, and other types of formats, but are they good enough, or are we looking at trying to develop alternate forms of web platforms that can really engage? And then, you know, what about hosting some of the boot camps or other resident type of courses online now, as opposed to canceling everything and postponing it down the road? What do you think?
So, Jim, I mean, excellent question, Jim. You know, I want to say I'm old school. You know, I like to give my presentations in front of a room full of residents. And as I'm giving the presentation, really looking at the residents to see, are they understanding it? I think with Zoom, with the web, as good as it is, we lose out on that personal interaction. And I will sometimes, you know, I will stop my presentation and ask a question of a resident just to see were they paying attention or not. And I don't know if we could do that with Zoom, with FaceTime. You know, what's to keep a resident from signing in and then walking away, you know, watching TV or playing on their Xbox or doing something else? Yet, as far as we know, they're signed in, they deserve credit for listening to that lecture or that dissection. So, you know, I don't think we're there yet.
Yeah, thanks.
Thank you. Can I just ask Dr. Boop to make any comments about keeping people? Dr. Boop, is your mic on? Yep. Oh, sorry, beg your pardon. Yep, Dr. Boop, you are now on. Sorry. Dr. Boop, you are on, sorry.
All right. Can you hear me?
Yep.
Just an elaboration on what George just said. there's a lot of attractive features to having conferences on Zoom that may be useful in the future. But when you look at an institutional culture and the culture that comes out of a residency program or out of a specific university, that culture is developed in the teaching forums that we have with our residents and faculty. It doesn't develop in the operating room. It develops in our teaching conferences. And so in thinking about the future and our teaching, we'll certainly incorporate Zoom for some things, but I still think you have to have the ability to get together once it's safe and to foster learning through personal interaction rather than over the internet, if you want to maintain the culture of your program.
Dr. Harbaugh, do you want to come in, please?
Yeah, I just wanted to note from the ACGME RRC perspective, we just had our first teleconference residency review committee a couple of weeks ago, and everybody on that committee recognizes how, you know, this epidemic is going to change things for neurosurgical resident training, and will be taken into consideration when we look at, you know, case numbers, et cetera, et cetera.
Dr. Professor Salomao, do you have, you have developed the whole pediatric neurosurgery in Brazil and South America. How are you viewing this crisis in terms of training?
Are you hearing me?
Yes, yes.
Oh, yes. Okay. We are now here in Brazil at the beginning of the pandemics. It's rising steadily at the moment, but we expect an increase in the next 2 weeks.
And in terms of the educational side, in terms of training side, is it just a bit too early in Brazil at the moment?
Yes, it's too early to define what is going on, but some epidemiologists are projecting something not so intense as in Italy, but not so mild as in Japan.
Thank you. Professor Grotenhuis, are you still there? What I will do is I will get Professor Salomao to, or Professor, yep, sure. Good. Yes,
it's
Professor.
difficult because it was muted. We have to realize that the whole training we do now is already changing in a certain way, that we have virtual environments for our residents to do so. But we have also the concerns that this still should not take over the whole kind of training. There is still a kind of one-to-one, and there is seeing that. I heard from Dr. Harbaugh that, and of course I fully agree with him, that now we are not scrubbing in with 2 or 3 or 4 people, but the most limited number that is possible. But for training, it is still necessary. There is still something like dissections, hands-on, and so, because this is surgical education, surgical training. And that is not only, I mean, virtual possibilities are good and are in the future will be adapted more and more, but it cannot fully replace it yet. And for everyone is now not taking actions because they think this will take, okay, some time, but not forever. But as we now realize, this will not be even the first and the last pandemic that we will see. So we more or less have to rearrange, and I look forward to Dr. Boop's presentation on how to prepare for the situation after this.
Great, thanks, thank you. I'm just going to thank you very much, George. I'm going to ask Dr. Professor Salomao to share his presentation. Prof Francesco, do you want to share your presentation, please?
Oh yeah, okay. Would you activate my share?
I have activated it. You on iPhone?
No, I blocked my presentation at the iPhone.
Sure. The presentation is on your name, is it? Just a second. Yeah, I'll just activate it. Great. Both of your computers are activated now. Great. Excellent. Thank you. Beautiful.
Do you hear me?
Yes. Thanks.
Do you see it?
Yep. Beautifully. Yep.
Yes. Okay. Thank you. This is what I'm doing, a literature-based observation according regulamentations and recommendations of the CDC, of the WHO, of the World Federation of Neurosurgery, and also specialty societies. When you look at the progression of the pandemics, you can see some similarity with this curve of the growth. At the beginning, we were shocked. Some denied its real importance. But now we are at the phase of anxiety, and some are now reaching the stage of acceptance of the situation and trying to deal with it in the best way we can. To start, the COVID is a pandemic that's still evolving, and this ultimate course remains unclear. It was already said, but it's important to emphasize this, that currently there is no effective medical treatment, and currently there is no vaccination. Regarding children, less than 1% of the cases are seen in children, and most infected children appears to have a milder clinical course than adults. And most of them are linked to, epidemiologically, are linked to adults, usually through familiar clusters. And asymptomatic infections were not unusual, so this patient becomes a vector for adults and other people. This is not a neurosurgical disease, but it's in fact patients, in fact healthcare professionals, and in consequence, as was already said, pediatric neurosurgery centers will have to be adapted to this new scenario, isolating infected or presumed infected patients from the rest of the patients. The challenge is, first of all, we have to think and stay safe then, dealing with patients, dealing with healthcare professionals, establishing decision-making processes, And in the future, we have to think in our meeting, in our congresses, in education and research, and the society itself, and its impact. So immediately, we have to follow the CDC recommendation with reduced exposure, stay at home for those senior members, isolation, and for healthcare personnel, we have to say that are at increased risk, because in most situations they are wearing without proper PPE, they are exposed to aerosol secretions, and most have prolonged contact with infected patients. Here is just two pictures to show how wearing a proper PPE, either by patients and by doctors, can change the outcome or the transmission of this disease. And in times of COVID-19, it's helpful to ask if we have staff enough. It seems that we're running out of staff, and we have to use, or already using, students, retired professionals, and staff may be redeployed from specialties to the areas of great need, of course, with additional training that should be rapidly provided. One question about our decision-making process. We remain with the basics procedures of medicine: save life, preserve function, avoid further harms for underlying condition, and identified critically ill patients. That's very important because we are having to postpone some program elective surgeries. So we have to minimize, cancel, or postpone elective surgery and endoscopy, if possible. We have to use virtual communication if our offices are shut. We have to make a routine virtual rounds in the case offices are shut, and that is happening all over the world. Our priorities are to deal with those life-threatening situations, such as brain tumor, malignant or non-malignant, especially those with hydrocephalus, but if it will include other brain tumors, hydrocephalus itself, infections, and trauma. In some cases, we have to consider temporizing measures such as ATV or even VPS. Consider temporary delay or reduction in chemotherapy intensity, but we have always to remember that brain tumors are usually emergencies, and the neurosurgical procedure will be emergent sooner or later. That's the reality. For those patients who remain at home, they may present to emergency room without diagnosis of the COVID, and so a high grade of suspicion is needed and testing is required for all patients. But as we know, testing is not we you don't have tests for everyone, at least in my country at the moment. And we have also to ask how long children with stable neurosurgical conditions can wait for treatment, and identify potential deterioration and treat these patients as an emergency. Consultation changed, and now we have to make an option for face-to-face for non-face-to-face consultation, teleconsultation, as it was also already mentioned. We need to have some recommendations and even guidelines. We are now in Brazil using some recommendations for the pediatric neurosurgery society, but we are working with members of ISPN in order to check these recommendations and improve it if needed. There are some basics requirements, set additional space for these patients because they should not be mixed with the other one. That means a reduction of standard neurosurgical beds. AR and ICU should be in separated spaces, but we know that recognize that this is not always possible. We have to be an enough amount of ventilator. We have to separate known from the suspect patients from the other without disease. We have to have a dedicated staff for these patients. We have to be proper cleaning supplies, and we have to have proper cleaning protocols. The burden of this situation is that we'll need medical beds expansion. We'll have to need ICU beds expansion. We have to cancel elective work, and we have to be prepared for a longer hospital stay. And of course, that will require extra funding. Regarding congresses and meetings, we have to follow World Federation recommendation and do not organize and do not support meetings until otherwise decided. Meetings are at the moment postponed for the second semester and should be also postponed for 2021. Some meetings have turned virtual. There is a cancellation rate of 15% according to our PCO, and we have to be prepared for the so-called acts of God and force majeure events that are outside human control and will require a negotiation with those who are programming, those who are organizing meetings. There will be many impacts on meetings. Some are here exposed: reduced long-haul travelers, reduced registration, reduced attendance, and reduced sponsorship. So we have to pay attention that meeting and courses plus annual fees are major sources of funding for our societies. So in consequence, we have to face with a sudden drop of revenues, with reduction of wages and payroll, with unemployment, and with the economic impact mainly in low and middle income countries. We can look at this situation as the black swan theory. That's an event that comes as a surprise, has a major effect, and is often inappropriately perceived as more predictable that they can actually wear. So in the day after, we have to think a lot in collaboration, in solidarity. We have to keep calm, we have to carry on, and we have to stay safe to deal with the others. Thank you. Okay, thank you.
È pronto Roberto? Ma no, sto vedendo, un attimo solo. Sì.
Do you hear me?
Everything is muted.
Yeah.
I think everything is muted here. I can't hear you, Naren.
You can hear me?
Yep.
Yes. Yeah.
Okay. I'll unmute all of you, but sometimes the noise just.
Yeah, but now I can hear you.
Okay, good. Okay, so maybe I'll just mute all and then come back. Just a second.
Sarà in inglese.
Good. Professor Grotenhuis, you are unmuted.
Yes, yes, that's fine.
Yeah. Dr. Harbaugh, do you want to? You want to say?
Oh, no, nothing. I just couldn't unmute myself.
Okay. In terms of the organizational thing, Professor Salomao, in terms of how's it going to economically hit? Is societies have enough reserve to withstand this, or for the how long can the societies go without having the normal funding sources and keep their staff?
Well, from the AANS side, I mean, I think our strategic plan for a long time was to have a reserve that would allow us to completely fund the organization for a year, even if there was no revenue at all.
Mm-hmm.
In general, about a third of the AANS revenue comes through an annual meeting, which is going to disappear. But I think, you know, as long as this is over in a reasonable amount of time, the organizations will be able to, AANS at least will be able to survive this on its reserves.
Probably AANS is probably one of the organizations with a good reserves. What about the European ones and the South American ones? Does Professor Grotenhuis have any thoughts?
Well, I think that also, I mean, the financial amount is different, but we would certainly can manage for a whole year without any major event that we would do. We don't have a lot of revenues from our training courses, who are very popular, but from the annual meeting, if that would be missed out, we could manage, but it should not go on very much longer, to be honest.
Mm-hmm. Professor Salomao, from your side, from the ISPN as the president?
Yes, ISPN at the moment has some reserves, and I think with high hope, we can keep the reserve during this period. ISPN is a very well organized and consolidated the society. and we were lucky. We had a very, very, very efficient treasurers during all these times. So I think that in the near future, we don't have any major problem. But anyway, we have to consider that maybe we have to be part of the day after, of the recuperation of finances, because it will be deeply jeopardized during this and after this pandemic.
Thank you very much. Professor Grotenhuis, do you want to upload your presentation, please?
Oh, no, the microphone, the video is gone. Let me see where I can do it, yeah. I think that should be this one here. Is it on?
Yep.
But now I don't see my own. Oh yeah,
yep,
here it is. Yes.
Thank you.
Well, I don't want to make this very long. We have heard many really good presentations. But as you asked me to address the psychological effects for neurosurgeons. I mean, as neurosurgeons, we are not a separate group. We are human beings. We are among our communities, and we are not different from anybody others because we see it around us. And any crisis, being like this pandemic, that will cause stress, anxiety, insecurity, and it is absolutely for everyone disrupting their normal life, not gradually, but all at once. And that's stressful. And the interesting thing is that because this has been studied from all the other crises, from world wars on, how you respond to that is not depending so much on who you are in your life, so not being a neurosurgeon, but it is your background, so that is part of it. But also it's depending on the community, because we are part of our community. And this is the similar picture that Dr. Jallo showed, and I was a little later than he had it. It's already indeed coming close to 700,000. So if I would update this now, it would be close to that. And you see this on a daily basis growing for 50,000. So if you have this information put on you, and that's one of the things that is different from other crises from 20, 30, 40, 50 years ago, this information is now overflooding us. And that even adds to stress and anxiety among everyone, so also among neurosurgeons. And beside the fact that this is a general situation for all the medical professionals like neurosurgeons, we are also considered to be a high-risk group. And that adds to the difficulty. And at least here in Europe, as as Francesco was telling in the first presentation already, 1 out of 10 registered cases is among medical professionals. And that also means that they probably will respond even more strongly to the stress that the general population already experience. And as we have heard that most of us, most of the neurosurgeons, we had to stop at least a large part of our regular and elective surgical activities. And even those activities that you do, the surgeries you do, have to be done under very unusual circumstances, sometimes in a completely other kind of performing surgery, as you see in this picture, which is actually a surgery performed in Wuhan in neurosurgical emergency on a COVID patient. And at least, as I mentioned in one of my questions previously, at least in Europe here, many hospitals, they have now organized it in a kind of centralized triage. So I know from our hospital, the chair of this triage committee is an ENT surgeon, then there is a general surgeon, an internal medicine doctor, infectiologists, some microbiologists, and they are looking at all the requests for having OR time. And as I mentioned, that is a stress extra, because that now they are giving the very restricted OR time for elective surgeries based upon, well, the committee's feeling. So I more or less, and I hope we can make this a little bit more interactive, I have two questions. So how would you cope? And I hope that everyone now in the chat room will answer to this. How would you cope with the fact that when an individual neurosurgeon considers a case to be urgent, but the others, like a committee who has to make the decision, don't see that urgency? And that's even a legal question, because legally, as a neurosurgeon, you are responsible of what happens to your patient if you have decided to take on the treatment of that patient. That adds to stress for neurosurgeon. How do neurosurgeons cope with this? And my second question to everyone is, how do we as neurosurgeons cope also with our personal fear and worries about our own health? Because you have to treat patients also in an urgent case, and you are simply not sure if the patient has been affected, yes or no. And then about the health of your family, your loved ones. Because if you get infected, they are also at risk. So these are my two main questions. That's all I wanted to add to this, and just say to everyone to please keep healthy and stay safe.
Thank you very much, Professor Grotenhuis. Certainly at the moment we are, I think it's two things. One is that we are doctors, and one is we are individuals, and another thing is that we have loved ones as well. Can I just canvas some comments on the psychological impact and how to cope, or whether we neurosurgeons are very good at blocking things? Dr. Boop? It's again me, sorry. Yep, thanks.
Yeah. Andre, your questions are germane. I had a 16-year-old athlete in the office this week who has a ruptured lumbar disc with a significant pain from a lumbar radiculopathy, and she's neurologically normal but suffering. And when I posted her initially for surgery, the response was, well, just keep her on narcotics for 3 months. Mm-hmm, mm-hmm. And none of us would want our 16-year-old daughter to take narcotics for 3 months.
Of course not.
And Jim had mentioned epilepsy surgery as not being urgent. I've got a child on for surgery tomorrow with catastrophic epilepsy from tuberous sclerosis who's having multiple seizures per day and has developmental regression. And although I could put that off for a couple of months, this child will lose significantly in their developmental abilities if I do that.
Absolutely. And that's a disruptive effect on our specialty, because in former times, this was easy for us to decide. We only had to decide among ourselves. Is that cervical myelopathy more urgent than your 16-year-old athlete with the herniated disc? We would find that easily to solve within in a staff. To say, okay, we schedule that one tomorrow and then the other one the next day. That's easy. And now all of a sudden we can't even schedule them. And that's hard. So I find some of my colleagues, especially the senior surgeons, having extreme difficulty in accepting this restriction. Because they say, this is not the care I want to deliver. This is not what this is, and indeed, we now have, this is triage. This is like in a war, like saying, this is the highest chance of survival, we take that one in. This is a very severe condition, but chance of survival is very limited, so we don't take them. So that's a hardship, but now we have to learn and have to deal as individual surgeons to make these kind of decisions that we never had to make earlier on during peace times. That's hard. That's very tough to do. And then, because also the second question, you do that at the same time, because I see that in the staff. There were two senior surgeons over 60 who said, well, I'm afraid myself. And then I see the younger staff who are in a active mode. They are saying, they took a 3-day course on how to use mechanical ventilation. They want to take shifts for also helping out in the ICU. So there is a really difference in how neurosurgeons can react to this, and that's very personal. So what I learned, I made some phone calls throughout the country. We are a very small community, so that's easy to do, and you see how that is different.
The thing is that at the moment, most of us in this forum are from developed countries. And as mentioned earlier, what is it going to happen when it hits the developing countries? And I think Dr. Rutka was making that point. We have got Marcel. Marcel, would you be able to say how things are in your part of the world? No?
Marcel, well, he is not muted, so I hope that.
And what about IMAD? I'll just unmute you as well. Unfortunately, this button where you unmute and mute is not that sensitive, so you have to
take some time.
You have to complete. Sorry. So we'll come back to that here. I've been trying to unmute.
Yeah, I'm back in. Yeah.
Okay, so I'm just going to get Dr. Boop to share his presentation. Dr. Boop, I'll just put you on the. Dr. Boop, you should be able to share your presentation.
But he's still muted.
Why is he still muted?
Yeah. Now it's fine.
Dr. Boop, you can share your presentation, Dr. Boop, on the system.
Is it showing up?
Yep, it is.
Okay. Yeah, I'm not seeing the slides.
You have to maximize it, Dr. Boop.
Yeah. There we go.
Yep.
Can you hear me?
Yes, we can clearly hear you.
So Naren had asked me to speak about the future of neurosurgery beyond the COVID pandemic. And this is probably a topic that lends itself best to conversation. So I thought I would start out, if we're going to look to the future, sometimes it helps us to look to the past and help and put things into perspective. So when we look to the past, let me pose this question. What is the most dangerous animal in the world to humanity? And I know Bob Harbaugh would probably say the Nittany lion. But when you look at the animal that's responsible for more loss of human life than the other, arguably it's the mosquito. Mosquitoes are vectors for at least 120 diseases. They've just been responsible for pandemics for centuries, including yellow fever, which came out of the building of the Panama Canal and spread about the world in the 1880s, malaria and so forth. And it's estimated that over the centuries, mosquitoes have killed somewhere between 3 and 4 billion people. Now, if I ask you what the second most dangerous animal in the world is, it's another animal that starts with an M, and that's arguably the marmot, because in times past, marmots were a dietary staple for a lot of Eastern Europe. And as they raised their young ones in their burrows, they would harbor fleas that carried the Yersinia pestis infection. And Yersinia pestis, as you can recall, has two forms of expression. One is a pulmonic infection, but the other is a lymphatic infection. And the marmots would get these buboes, or hemorrhagic inflammations of their lymph nodes in the armpits and the axilla that were recognized even back in the Middle Ages. And as you know, the bubonic plague claimed roughly a third of the population of Europe at its peak. Anyone who's interested in looking at Ingmar Bergman's old movie, The Seventh Seal, it's a great example of what life must have been like during that time. The picture before you is a picture from the 1918-1919 Spanish flu. And remember, this flu was probably born out of the trench warfare at the end of World War I. It was an H1N1 virus, influenza virus. And as the soldiers at the end of the war returned home, they brought the flu with them. The soldiers in the boats coming across the Atlantic brought it to North America. And in its pandemic, the Spanish flu was responsible for some 50 million deaths over a short period of time, which was an estimated 1 to 2% of the world's population at that time. The H1N1 is now a standard part of our flu vaccine, and so most of us are protected from the Spanish flu. But lessons learned in ancient pandemics are not dissimilar from what we're seeing today. For example, in the era of the bubonic plague, we worked that quarantining sick patients protected those who weren't sick. We learned that self-isolation protected people from getting infected. This was hundreds of years ago, but people would board up the doors, the gates to their city, and try to keep infected patients with the plague out of their city to prevent the spread. Similar to today, one of the most impactful measures that we have in preventing spread of the COVID virus is hand washing. Hand washing was first described by Ignaz Semmelweis in trying to prevent the spread of puerperal infection. He was a Hungarian obstetrician who wrote on this, and tragically, his thoughts were so out of the mainstream that the medical community had Semmelweis eventually committed to an insane asylum for promulgating the idea that doctors could be responsible for causing infections in their patients or the spread of disease. And tragically, 2 weeks after he was in the insane asylum, Semmelweis got into a fight with the guards there, and the guards beat him to death because his theory that hand washing was the cause of disease was not well accepted. Likewise, in previous pandemics, it's been documented that the political leaders of our countries have tried to minimize the severity of the disease in order to keep their population calmed down. And when the disease moved rampantly, despite the politicians' predictions, then the population lost their confidence in their leaders and viewed them as either dishonest or disinformed. And you were seeing this across the world again today. So I've asked Naren to share with all of you the link to a Bill Gates YouTube TED Talk that he gave in 2015, in which he proposed that the world was not prepared for a pandemic. And we can easily wish that we'd listened to Bill Gates 5 years later when we're going through this. Hopefully you'll get a chance to view it. I would point out that one of the advantages we have over the history of pandemics is our global ability to communicate and to cooperate. And it's essential that we work together across borders to learn from one another and to not only help limit the spread of the disease, but also to come up with the latest, most rapid advances in diagnosis and treatment. We saw yesterday in the United States that Abbott Labs has just come out with an FDA-approved diagnostic screen for the COVID virus that gives you a positive or negative answer in 15 minutes. And they'll start this week rolling out 50,000 of those tests. The test machine is a 7-pound machine, which is portable, so it gives us tremendous opportunity to make earlier diagnosis with these patients. Francesco mentioned earlier that it took too long to get the diagnosis back, and they were doing emergency CTs of the chest to look for signs of influenza or signs of pneumonia. This may be an opportunity for us to get a more rapid diagnosis. I think, as George said, education will probably never be the same. It's going to be a long time before we'll be comfortable sitting in a room together or sitting around a conference table with our residents having a common chat. And for now, I think Zoom and other online avenues of education have given us tremendous opportunities that we're learning to take advantage of. But we're also going to learn the consequences of being separated and not having the personal interaction that we've had over time. In terms of sharing across borders, the ability to set up resources quickly, like we've seen from China, and learning how to care for these patients, what their needs in the majority are, how to stockpile resources that we're going to need as the infections start to ramp up, and then how to dispose of the consequences of the disease is going to be problematic. In terms of travel and leisure, I can't imagine any of us getting on a cruise ship and going for a cruise in the next few years. It's going to take a long time for any of us to be comfortable with this sort of leisure, but even getting on an airplane and flying across the country is something that none of us are going to be willing to do for the next several months. And perhaps having a vaccine come available will make us all feel better about being close together and sharing public spaces, but we're certainly a long way from that, from where we're sitting today. And then the economy, the trillions of dollars that have been lost worldwide and will take decades for our children to pay back long after we're retired or even dead is something that's going to be hard to contemplate. And then the effects on society, going to an opera, going to a movie, gathering in public for a protest, going to a rock concert, music concert, getting together for a sporting event. Here's where we are today. How long is it going to be before we're comfortable sitting in the soccer stands and watching a football game? It's going to take some time for us to get beyond where we are at the moment. In terms of neurosurgery, I think we've heard a lot this morning, and Francesco's talk was particularly touching, how our resources as being 1% or less of the healthcare pyramid, being small but highly specialized members of the medical community that are essential to healthcare. We can't do without neurosurgery, but oftentimes our patients are sick and they can use a lot of resources at a time where resources are precious. So being able to make a rapid diagnosis, avoiding things like intubation, transsphenoidal surgeries, dental and oral surgeries when possible, and shielding ourselves appropriately. We heard from Francesco that it's very difficult to use a PPE helmet to look through the microscope to do microneurosurgery. And we're going to have to figure out how to stay safe ourselves, how to rapidly diagnose the patients so that we don't operate on patients with active disease, but protect our patients from our governments and from our colleagues who view neurosurgery as an expensive waste of resources in the midst of a pandemic. So let me go this way. And finally, as I think about it, it was very poignant this last week on the ISPN listserv and the ASPN website when we recognized that Jim Goodrich, someone that we all know and love, is fighting for his life in the intensive care unit in New York with this disease. And when we look around and think that 5 to 10% of the people that we know, work with, care about, the nurses and doctors that work with us, the residents and medical students that we train, may not be there when this is over because they've either died or become pulmonary cripples from the long-term effects of this disease. It's very hard, and it's going to take us a tremendous amount of time to get over this. So I ask that everybody on the listserv give a prayer for Jim Goodrich and hope that we see him back at our meetings again in the future. And I'll stop there. Thank you.
Mute again. Thank you very much, Dr. Boop. Certainly, Dr. Goodrich is in all our thoughts and prayers. It does bring it home, but I hope I pray that he will pull through. It's a new pediatric neurosurgery without Dr. Goodrich is certainly not something I'm ready to contemplate for the next 10 years. Any thoughts from other members of this meeting? Shall I just open up Prof Wagner, Wolfgang Wagner? I'll just get you. Prof Wagner, any thoughts on what the future you have been in a country where country had been rebuilt? Where do you think we are?
First, Naren, thanks for organizing such a meeting. Thanks for those who have given these highly interesting and touching talks. I think in the current situation, this is so precious, so important to learn from each other, to learn these experiences. And it's Europe. I must say that it's not only in Italy, particularly in northern Italy, but also in France and Spain, and it's also getting worse in Germany. And it's so important to learn from our neighbors, from our friends, to, if possible, to avoid the effects that they have already experienced in their own country. And I must also say that we are, if I can say that, sitting between two chairs in this situation. On the one side, we are responsible for COVID, for those who are already infected, and for those we try to protect from an infection from COVID. But on the other side, and this is something that came through more by the last presentations by you, we are responsible also for those patients who are ill not from COVID, but from other diseases. And it's a little bit provocative to say that here, but in such a situation in the population can evolve the attitude that if a patient dies from illness, and people ask, oh, did he die from COVID? Oh, it was not COVID. Then thanks God it was not COVID. But if a patient dies from illness, it's not less traumatic if he dies from another disease than if he dies from COVID. So we are, and this is very, very, very difficult for us. We are responsible for both the COVID and for both all these other patients that have other diseases that are not less severe. And one of the problems after the COVID pandemic has happily ended, these are of course economic problems and so, but also we have then to take care for all the patients that we have now postponed in treatment. A treatment that can be postponed for several weeks or even months is not necessarily a treatment that is not important or perhaps not really necessary. But as we heard from this one patient, from Rick Boop, with a severe pain from slip disc or something like that, that's not life-threatening, but this patient is suffering, and we will be responsible for all these patients to give them the care they need also after the pandemic. And this will be, particularly for us as doctors, a very, very large task in the future.
Thank you. Thank you very much. Dr. Rutka, do you have, I'll just get the, sorry. Dr. Rutka, your thoughts, overall thoughts on the challenges that we all face as neurosurgeons?
Yeah, thanks, Naren. I mean, Rick's presentation I thought was excellent to summarize not only what we're facing, but what lies ahead for all of us in the future. And as I mentioned, and many did too, the worst is yet to come, I fear, for some of our countries. And you had brought up the point about the low middle income countries. They have no chance to isolate themselves, to access care in hospitals, on ventilators. It's a real problem. I fear for countries like India. India is just starting to take off, and imagine when that population gets affected with the limited resources available in many regions of India. It is going to be horrific in my view. I also fear, and it hasn't been brought up yet, but our experts in Toronto are saying there's a wave now for sure, but in North America at least, there's a concern about another wave coming in September or October. So all of what we're talking about meetings being canceled or postponed or whatever, trips and so on that are postponed, I mean, that it may be a long time, many months before, just as Rick said, we'll all feel comfortable getting on airplanes again or sitting in crowds and so on. So it's really reshaped the way that we think about human gatherings. And that's why Dr. Jallo's presentation about future education and how we can try as much as possible to salvage aspects of our training, even if it's not hands-on, but something at least at times of crises like this, so that we don't lose opportunities to teach and educate, recognizing that it's not the best, but at least it's a source of education, and looking forward to those days when we can get back together again and conduct business as usual. But Naren, thank you for organizing today's session.
I just want to take the liberty on two aspects. One is that in terms on one is about the online educational side of things, the capability. The other side is that if you all will be kind enough, I think Dr. Boop was keen. I think it's worth seeing that video of Bill Gates because it's a salutary story about someone warning. But first about the educational side of things, in terms of for example, the Zoom platform, it can easily extend to 1,000 and it can easily extend to 10,000. That's not a problem in itself in terms of the mass education. Prices are not, for an organization, it's not a big deal. The prices are very reasonable as well. The number two is that in terms of when you are teaching to a student, whether he's concentrating or not, actually it has got an AI on the system that if someone is not watching the screen, then it automatically flags up saying they are getting bored with your talk, and then you either ask them to look at your talk or so. In terms of there is probably a bit too intrusive technology there. The other thing is that the learning management system is now so advanced and so easy. What it means, learning management system, is that you put your PowerPoint presentation in a quiz or you put a video, and then people look at it, answer questions. It can be essay exam, essay. It's not just MCQ, it can be an essay and you can get it corrected. So there are many options there. The paid options, one is from something called iSpring, and that costs about £3.50 per person per month, but you have to minimum buy 100 license. That takes you to £3,000. And what you call in terms of so that's but it's an amazingly powerful platform. You can probably, in terms of not the hands-on teaching, but the other teaching, you can probably do better than we used to do when we were sitting around looking at other people whilst the lecturer was doing the talk. And the thing is that, once again, like this webinar, it can be recorded and played back. Then Google has done a great service as well, the Google Classroom, that is available for universities with a much higher facility, and also Google Classroom is available for us as well. And once again, you can really push a lot of education through those portals. So they are the two things I wanted to say. Certainly not on hands-on, but on the other side, there's a lot of cheap but excellent alternatives out there. The important thing is that if you do go, it's not so expensive to actually. It's not difficult to do them. Okay, it does takes a bit of time, but if you go to the IT professionals, they will ask for arm and a leg. But I think there's enough. The kids. I was talking to my nephew. He's 13 years old, and I thought I better teach him how to do some software programming. And he said, well, I'm learning Python at school. And I was like, look, I haven't touched the Python yet. So, I think our residents are very clever, and I'm sure many of them will be happy to, help out. And I think there's once again, we can mobilize that. The other thing is that, Gene Walter mentioned that they are running a survey on the COVID-19 and the impact of on neurosurgery. So there are links, and I have already sent that to Adrian Caceres, sent it in the listserv, so please do fill it. I'm just going to show you that video. of that Dr. Boop had suggested. Hopefully it runs. So this is from 2015. I hope you can hear it.
When I was a kid, the disaster we worried about most was a nuclear war. That's why we had a barrel like this down in our basement filled with cans of food and water. When the nuclear attack came, we were supposed to go downstairs, hunker down, and eat out of that barrel. Today, the greatest risk of global catastrophe doesn't look like this. Instead, it looks like this. If anything kills over 10 million people in the next few decades, it's most likely to be a highly infectious virus rather than a war. Not missiles, but microbes. Now, part of the reason for this is that we have invested a huge amount in nuclear deterrence, but we've actually invested very little in a system to stop an epidemic. We're not ready for the next epidemic. Let's look at Ebola. I'm sure all of you read about it in the newspaper. Lots of tough challenges. I followed it carefully through the case analysis tools we use to track polio eradication. And as you look at what went on, the problem wasn't that there was a system that didn't work well enough. The problem was that we didn't have a system at all. In fact, there are some pretty obvious key missing pieces. We didn't have a group of epidemiologists ready to go who would have gone, seen what the disease was, see how far it had spread. The case reports came in on paper. It was very delayed before they were put online, and they were extremely inaccurate. We didn't have a medical team ready to go. We didn't have a way of preparing people. Now, Médecins Sans Frontières did a great job orchestrating volunteers, but even so, we were far slower than we should have been getting the thousands of workers into these countries. And a large epidemic would require us to have hundreds of thousands of workers. There was no one there to look at treatment approaches, no one to look at the diagnostics, no one to figure out what tools should be used. As an example, we could have taken the blood of survivors, processed it, and put that plasma back in people to protect them. But that was never tried. So there was a lot that was missing, and these things are really a global failure. The WHO is funded to monitor epidemics, but not to do these things I talked about. Now in the movies, it's quite different. There's a group of handsome epidemiologists ready to go. They move in, they save the day, but that's just pure Hollywood. The failure to prepare could allow the next epidemic to be dramatically more devastating than Ebola. Let's look at the progression of Ebola over this year. About 10,000 people died, and nearly all were in the 3 West African countries. There's 3 reasons why it didn't spread more. The first is there was a lot of heroic work by the health workers. They found the people and they prevented more infections. The second is the nature of the virus. Ebola does not spread through the air. And by the time you're contagious, most people are so sick that they're bedridden. Third, it didn't get into many urban areas, and that was just luck. If it had gotten into a lot more urban areas, the case numbers would have been much larger. So next time, we might not be so lucky. You can have a virus where people feel well enough while they're infectious that they get on a plane or they go to a market. The source of the virus could be a natural epidemic like Ebola, or it could be bioterrorism. And so there are things that would literally make things 1,000 times worse. In fact, let's look at a model of a virus spread through the air like the Spanish flu back in 1918. So here's what would happen. It would spread throughout the world very, very quickly. And you can see there's over 30 million people die from that epidemic. So this is a serious problem. We should be concerned. But in fact, we can build a really good response system. We have the benefits of all the science and technology that we talk about here. We've got cell phones to get information from the public and get information out to them. We have satellite maps where we can see where people are and where they're moving. We have advances in biology that should dramatically change the turnaround time to look at a pathogen and be able to make drugs and vaccines that fit for that pathogen. So we can have tools, but those tools need to be put into an overall global health system, and we need preparedness. The best lessons, I think, on how to get prepared are, again, what we do for war. For soldiers, we have full-time waiting to go. We have reserves that can scale us up to large numbers. NATO has a mobile unit that can deploy very rapidly. NATO does a lot of war games to check, are people well-trained? Do they understand about fuel and logistics and the same radio frequencies? So they are absolutely ready to go. So those are the kinds of things we need to deal with an epidemic. What are the key pieces? First is we need strong health systems in poor countries. That's where mothers can give birth safely, kids can get all their vaccines, but also where we'll see the outbreak very early on. We need a medical reserve corps, lots of people who've got the training and background who are ready to go with the expertise. And then we need to pair those medical people with the military, taking advantage of the military's ability to move fast, do logistics, and secure areas. We need to do simulations, germ games, not war games, so that we see where the holes are. The last time a germ game was done in the United States was back in 2001, and it didn't go so well. So far, the score is germs 1, people 0. Finally, we need lots of advanced R&D in areas of vaccines and diagnostics. There are some big breakthroughs, like adeno-associated virus, that could work very, very quickly. Now, I don't have an exact budget for what this would cost, but I'm quite sure it's very modest compared to the potential harm. The World Bank estimates that if we have a worldwide flu epidemic, global wealth will go down by over $3 trillion. And we'd have millions and millions of deaths. These investments offer significant benefits beyond just being ready for the epidemic. The primary health care, the R&D, those things would reduce global health equity and make the world more just as well as more safe. So I think this should absolutely be a priority. There's no need to panic. We don't have to hoard cans of spaghetti or go down into the basement. But we need to get going because time is not on our side. In fact, if there's one positive thing that can come out of the Ebola epidemic, it's that it can serve as an early warning, a wake-up call to get ready. If we start now, we can be ready for the next epidemic. Thank you.
Thank you very much. Thank you very much to everyone. I'm going to give the last comments to Dr. Professor Wagner to sum up the whole meeting and where you think that we can go as neurosurgeons and whether we have another, what's your thoughts? And just a second, I'll just off the phone. The other thing is that just, as one of a sage politician, once again, very good-hearted, but not so heard, he said, we are as good as our neighbors. And that goes for not our next door neighbors, but also our other countries as well. So I will just, Dr. Professor Grotenhuis, so Professor Wagner, could you please make the closing comments for us, please?
So I think there is nothing to summarize. We already heard that, and I have said it. I just want to say at the end that I'm very, very grateful to all of us, to you, Naren, to all those who have given their very important tasks and contributions. And I very hope for the near future, for the very, very near future, that we can cope with such a pandemic, that we learn lessons for the future, but we must stay aware that nobody of us can really know the future. There will happen once more any catastrophes, and so let's try to be prepared for that, but let's not forget that there will be problems in the future we will cope with, but we will still have to learn to cope with also in the future. So I hope for all of you to stay healthy, for your family, for your hospital, for your colleagues, and for all of us. Thank you.
Thank you very much, everyone. With those words of encouragement as well as fortitude, I will formally close the symposium, but I'll leave the Zoom running. If anyone wants to discuss on the side or on the panel, then they are welcome to do so. But thank you very much to everyone. Certainly our North American colleagues coming at this early in the morning, that shows what caliber you are and how much you are committed. And to Professor Grotenhuis, Professor Wagner, this has been real support. And Francesco, I wish you all the best, and we are not far from you, and we are all thinking of you, and you have to think about us as well. And please, my favorite country is Italy. My highlight of this year for me was to go back to teach in Italy in July. I'm sure it will be again soon. I look forward to it. Thank you very much again.
Bye-bye.
Bye. Thank you very much, Aaron. Thank you for everybody. Thank you.